Hi everybody, my name's Mervyn Morgan. Thank you for joining us tonight for our COVID-19 vaccine and booster Zoom session. We've had loads and loads of questions come in. First of all, though, I'd like to introduce the people who are here. We have Professor Adrian Newland, Chair of the ITP Support Association. Hi, Adrian. Then we have two of our esteemed medical advisors, Dr. Vicky McDonald from the Royal London. Vicky also manages the adult ITP registry. And from Oxford University Trust, Dr. Sue Pavord. Hi, Sue. Hi. In addition, we've got board member Derek Elston. Just give you a wave, Derek.
Everybody.
And senior patient advisor, who I'm sure most of you will know, Mrs. Rhonda Anderson.
Good evening, everybody. Nice to see you all.
All right, just a few things, because we've got quite a few people and there's still people coming on now. If I can just ask that if you're not, only unmute if you're asking a question. If you do want to ask a question, put your hand up. There's a button down the bottom, reactions, and there's another tab in there that says raise hand. So just do that. Before we get underway, just a reminder, this is being recorded because lots of people want to sit, sort of watch this after the event. But we're going to kick off. I've asked Dr. Sue Pavord to just give us a summary of the findings from the ITP Support Association's COVID vaccine survey that's been open since the vaccines started being issued. Sue has kindly agreed just to give us a brief summary of some of the findings. So Sue, over to you.
Great, thanks very much, Mervyn. Okay, so can everyone see this slide?
Yes, we can, yeah.
Okay, great. So for those of you who were at the ITP Support Association last year at the conference, I presented this. So you very helpfully put your data onto an ITP Support Association database, and we were sort of looking at your experiences with the vaccine. So at this time, there were 179 patients, this was last year, who had received the COVID-19 vaccine. And then when we boiled that down to how many had submitted a pre and post platelet count, there were 14 of 66 patients who had received the Pfizer vaccine who had submitted a pre and post platelet count, and you can see that the majority did not change at all, but one patient had a significant relapse with a platelet dropping right down to 0. With the AstraZeneca, things were a little bit different. So there were 107 people with ITP who had the AstraZeneca vaccine, of which 16 had reported a pre and post platelet count, and every single one of them had changed their platelet count in one way or another, apart from one where it stayed the same. So the AstraZeneca, half the cases went up and half the cases went down with the platelet count, but there were only 30 patients in total who had reported a pre and post platelet count following COVID vaccination. So this is the situation now with the updated database that Mervyn sent me a few weeks ago. So this is the AstraZeneca. There were now 41 patients who had received AstraZeneca and had a pre and a post platelet count checked. 40% increased their count, 53% reduced the count, and in 7% there was no change. So you can see 53% reduced their count in that big red slice of the pie there. With Pfizer, it was fairly equal. So about a third reduced, a third increased and a third stayed the same. So there were 31 patients who had received the Pfizer vaccination who had a pre and post platelet count. And with Moderna, there were only 4 patients who had received the Moderna vaccination. One of them had, 3 out of the 4 had reduced the platelet count. So that's the sort of absolute values. When we looked at this statistically, with some clever stats applied to all of that, we found actually that there was no significant, what we call statistical significance. There was no statistical significance of a change in platelet count with those vaccines. And we have to be very mindful that this is very limited data. We don't know at what point pre-vaccination the platelet count was done and what point after the vaccination the platelet count was done. There may also be a bit of reporting bias. People with ITP who are particularly anxious or who are particularly engaged in the ITP Support Association, maybe those with more severe ITP. So we have to be mindful of all those limitations. But I think it's consistent with national and international data that the AstraZeneca vaccine does cause a little bit more in the way of problems. And certainly when we look at new ITP, there was 1 new case of ITP per 100,000 vaccinations with AstraZeneca, with a big Scottish study looking at sort of over 2 million. And that was not observed with the Pfizer vaccine. So it seems our data, with all its limitations, seems to support that AstraZeneca causes slightly more problems, but both are unusual, and the statistical significance was what was not there in this data set. So happy to answer questions about that.
Any questions, anyone, on the data?
Can I ask Sue if she knows from the data how many of those patients required treatment and how quickly the count came up? Do we have that data?
We don't have that data, but the data we know from national and international studies is that the majority of patients who reduce their platelet count with the vaccine are treatable. It doesn't seem to be more resistant ITP than ITP unrelated to a vaccine.
Okay,
Great.
I've actually got a couple of questions here sort of linked in with this, mainly around the AstraZeneca. One of them, this is from Lisa. My AstraZeneca vaccines took me out of remission and maybe from septic. Should a booster be risked if you're still isolating and shielding as much as possible with little or no social contact? And another one, why did the AstraZeneca vaccine react as it did with my body to create ITP? I already had an underactive thyroid, but so do many of my friends who didn't develop the condition. Don't know any answers from that, anyone?
Well, we know that the vaccines are immunomodulatory. That's how they work. Viruses themselves are immunomodulatory. And we know that the AstraZeneca vaccine appears to be a bit more so than the mRNA vaccines like Pfizer. So it has been found that they can induce these antibodies to the platelets.
Okay, and there's also a question on from Beverly. She says this data set is for pre-existing ITP, which it is. Do we know what the situation is for non-pre-existing ITP?
I was going to say the data is
the
data is there from the yellow card schemes that are put into the MHRA, which is interesting data, and that shows again, as Sue has just said, increased instance for the AstraZeneca vaccine. It's about 20 per million have a reduction in platelet count with the AstraZeneca vaccine. These are people who were previously normal, or we assume are normal. With the Pfizer vaccine, it's about 5 per million. Now, of course, it's interesting to know that in the normal population, the incidence of ITP is something like 60 per million. So it's not so the vaccine is protecting them from having a low platelet count, but it's strange that the numbers are quite small. And I think it's interesting to speculate. We know when you get true thrombocytopenia as a reaction to vaccines, not just COVID, it comes on after 2 to 3 weeks. And some of these reductions come on with a day or two. And I find it hard to believe that you're developing an immune reaction that quickly. And I wonder whether some of these actually have pre-existing ITP that's never caused them problems or been picked up. But the simple answer is yes, it does occur with the vaccine in normal people. It's the same balance as we see in the survey that Sue was talking about, and it's slightly worse in AZ. But as I said, not significantly worse than we would expect in a normal population presenting with ITP in a normal year.
And in addition to that, it seems on a par with vaccines like flu and MMR and hepatitis B. So the COVID-19 vaccine doesn't appear to be any, to cause more ITP than those ones.
Yeah.
Thank you, Sue. I see the lady who asked that question, Beverly, has got her hand up. Beverly?
Yeah, I went from about 219 as a pre-existing platelet count down to 5 from March the 21st. Started getting all the petechiae and everything around about the middle of April, and finally was given a blood test on the 5th of May when my platelets was 5. And I've been on a huge number of treatments since then, currently on MMF. And it's not shifting, it's sort of sitting 5, it's coming on 7. That's why I'm interested in what the data might be for people who had non-pre-existing ITP. That's why that's obviously particularly interesting to me.
Okay, Vicky, Sue, Adrian, any comment on that?
I was just going to ask Beverly, what was the time period after receiving your vaccine? Was that your first vaccine, and which one? And what was the time period between that and you presenting with your ITP?
So yes, it was AstraZeneca. It was my first. I had the injection on the 21st of March 2021. I started to notice the petechiae and bruising through the course of sort of middle April, and reported it into my GP, who then 18 days later did a blood test, which was the 5th of May. And that went into the hospital, and they rang me in the afternoon and asked me to come in straight away. So that was sort of, so over the course, therefore, between being seen by the hematologist, by the consultant, and having the jab was 21st of March through to the 5th of May. Okay,
that's the timing is really important. So we asked for the yellow cards for instance, to the MHRA if it's within 30 days of the vaccine. Now, obviously, the time your platelet count was checked was beyond 30 days, but you said before that you'd had some symptoms of a low platelet count, so you're just within those 30 days. So we would count that as potentially vaccine induced. We can't be sure, and as Adrian said before, it might, these things happen by chance as well, as they do with the COVID-19 infection. You've been unlucky, Beverly, and you've obviously required a lot of treatment to manage your ITP. That is unusual, and as Adrian said and I said earlier, the AstraZeneca is more immunogenic than the others, but it is still very rare. We're looking at 1 case per 100,000, so that's possibly been you.
It obviously doesn't help you, but you obviously had to have a lot of treatment, and you are at the more severe end of the spectrum of that. When we looked at our data and looked at the data that the Americans collected, which we published, very few patients required major treatment. Most bounced back very quickly with a small dose of steroids or sometimes something else, but in general, it was relatively transient and came back to normal. And it's unfortunate that you've fallen into that category that's actually needed quite major treatment. And it certainly sounds like it's a true ITP.
My consultant describes it as refractory, and I've been on rhomboplostin, Revalade, Rituximab, I did the steroids, and I'm now on MMF at 1500 twice a day. So we'll see if something will work. Recalcitrant, I think is the way he calls them.
Okay, thank you, Beverly.
Reach out. I think he will be reaching out to you and others because he's looking for, I would say, a very eminent consultant hematologist, but he's tried quite a lot of different things so far. So
yeah, he's very welcome to. We have a big group from the UK ITP forum that Adrian and Vicky are part of, and several experts, or many experts in this field. So no doubt your case will be discussed.
Thank you very much, Brenda. Lisa, you got your hand up.
Thank you. Yes, it was just unmuting. Just to follow on from just the question that I sent into Mervyn, my platelet count doubled and went up to over 500, and it's stayed there and not gone back down. My question was, is it worth risking a booster? Because I wouldn't like it to double again.
Well,
Okay, who's going to ask?
I think you can't necessarily predict what will happen with the second injection with what happened to the first. And certainly we have much more experience with vaccinations in children. And we don't think that a platelet count fall in a child prevents you from giving it giving further vaccinations. Now, I know your count went up, and I have to say pre-COVID, this is not something that's been particularly well recognized or understood, but that's perhaps not unusual, because it's not usual to check platelet counts in people who have routine vaccinations. It's because obviously the COVID vaccine has been given to so many people in such a short period and has been so closely monitored that we're picking up these things. But what we have picked up, and certainly this is looking with the American data as well, and the data through the MHRA, the reactions to the platelet count, thrombocytopenia in particular, which is what they were looking at, is much less common with the second vaccine than it is with the first. It does happen, but it's much less common. Whether that's the same for the thrombocytosis, which is the platelet count going up, I don't know. Certainly in the ones that we've looked at, I don't think we've recorded it, but I haven't looked at the latest data in great detail yet. It
was nice not to be an ITP person anymore, but I didn't particularly want to be thrombocytosic either. So that was just my concern, that it would go up again. And then obviously I'm taking aspirin, but it would be bigger doses of aspirin. And it was just the concern around, potential for strokes being increased, etc., which was the worry. I've had the 2 AstraZeneca vaccines. I'm now in quandary as to whether to have the booster as well.
Actually, my next question was going to be, are you taking an aspirin? But I have to say, my advice is the benefits of the booster are such that you ought to consider it.
Okay.
Lisa, did they go up after both? Did they go up after each jab and then go
after
down?
Each one? Yeah, so it went up after the first one, and then it went up again after the second one. So I know it's a different vaccine. It's not an RNA vaccine that we're giving me this time. I think it's either Pfizer or Moderna where we are. But I just did wonder, thinking, I don't really want to go up again.
Yeah. And did you go? Did it go from low to very high, or were you?
It was around 250s, okay. 250, 260s, and then it went up to about 370, 380, and then it went up to 525, and that's where it stayed.
Yeah, I mean, I think probably worth an aspirin, although it's really difficult to know at that level whether, I mean, there are some conditions where your platelets go up and we do worry about an increased risk of strokes, but that's usually driven by something that makes the platelets more sticky, as it were. But I mean, yeah, an aspirin to protect yourself. I mean, you don't. COVID can cause all sorts of problems with platelets and other things as well. And I think, generally speaking, for the patients that we've seen the platelet count go up, we've not run into anyone for the numbers that we've had through our clinic, and we've probably got about 200 with information now, and I think we've not seen any thrombotic events when the platelets have gone up. They've gone up and eventually come down, and you know, taking an aspirin is a good thing to do if you're worried about that, but I think it is actually quite unlikely.
Okay, thank you very much.
And I just add that from the MHRA data that came in on the yellow cards, while thrombocytosis, the platelet count going up, was reported with the AZ vaccine, and it was, although the platelet count going down was much more, it was reported with the AZ vaccine. It wasn't reported with the Pfizer vaccine, and that was at a time when something like 20 odd million Pfizer vaccines had been given. So that's a large number and no reports of an increased platelet count with the Pfizer vaccine.
Thank you.
Mervyn, you're muted.
Yeah, there's a lady who was holding her hand up.
Yeah, it was me and Brooks.
Yeah, we can't see you now. All we can see is your tablecloth.
Just 1 second. Oh dear. Can you hear? It doesn't really matter.
We can hear you. We can hear you.
Okay.
Far away. Yeah.
So I've known about ITP for 2 years. I've had it for 2 years, and my count is usually just above 10 or below 10. With treatment, it can go up, but it always goes down. However, I've had all my vaccines and all my boosters, and each time it's pushed my platelets up to a more reasonable level. Although after 3 months, they go back down to the lower levels. I mean, has there been any suggestion that these vaccines might be a way of conveniently keeping the platelet level at a more acceptable count?
No. An interesting suggestion, but no, I think is the simple answer, which is a shame.
It seems much easier than having infusions and things like that, which are much more cumbersome. Yeah. I mean, just to have a vaccine and that's going to do the trick. But
I mean, it's an interesting concept, and I guess, as Sue said right at the beginning, the vaccines are, you know, they are there to cause a degree of immune modulation, because they're there to get you to make a response to something so that you can lay down a memory and make a response more rapidly the next time you come across it. And I'm hoping that actually what we've seen in these phenomena are allowing us to learn a little bit more about this, actually, and it is allowing, I know it doesn't help anybody right now, but actually there's quite a lot of research has been started and it is underway around what's happening in different autoimmune diseases with these vaccines, picking up kind of trends and groups of patients, and perhaps looking at why people have responded differently. So, sorry, it doesn't help you right now, but, but I think it has generated quite a lot of interesting discussion about. We've learned quite a lot, and the other thing we've learned quite a lot of, just talking about the kind of research and settings, is, for example, we have changed the way we've managed ITP a little bit around the COVID pandemic, and this is more around COVID than vaccines. Just about the sequence in which we've used some medicines to try and keep people well, where possible, and I think, you know, it's opened up an opportunity for us all to work quite closely together to learn from these things. So hopefully, if we don't have an immediate answer for some of those questions that are coming today, I'm hopeful that actually we will, because I think we've worked very hard as a group of treating haematologists to try and understand this a lot better for people, and in more detail. But a good question around immune modulation and ITP.
Yes,
Well,
I
thank
mean,
you, thank you for your answer.
it's worth adding that we already know that when patients with ITP get an infection, sometimes the platelet count falls and sometimes it goes up. And that's probably a reflection of the immune process of inflammation and the body reacting in such a way that some of the substances it produces actually do stimulate platelet production. And that's probably what happens after the vaccine, but it is only a transient phenomenon.
Okay, thank you very much.
Okay, on the chat, there's one from Rupa. When having the vaccine, first to be an AstraZeneca, she was told it should be given the Pfizer as her third dose, and then the booster would be given in 6 months' time. Is that what the process is for patients with autoimmune conditions, to be given 3 doses, then a booster? I know we've had this question before, haven't we? So, yeah.
Many people will be offered that 4th injection if they're on immunosuppressants. So, Rupa, are you on mycophenolate or rituximab or an immunosuppressant?
She may not be on the call.
Okay.
Yes, she is on the call, yeah.
That's often why people get an extra vaccine in comparison with everyone else. So that may well be the case.
I mean, there are other criteria. There's age. I mean, there's a few other criteria whereby the terminology is that the first 3 are actually your primary course. So, and your 4th is your booster if you're considered even more vulnerable, as it were. So, yeah. So for the majority, the course is 2 and the booster is 3. But for those who are felt to be at greater risk or perhaps not mounting the response that they might ordinarily mount, either through immunosuppression, age, or potentially other risk factors, then your primary course is 3 and your booster is the 4th, if that helps clarify as well, Rupa.
But it's worth emphasising, isn't it, Vicky, that for a standard patient with ITP who's not on any treatment, has no other risk factors, they aren't at risk of getting COVID, and that the standard format of 2 doses and a booster is absolutely fine. It's only, as you were saying, for those with other risk factors where you would consider the 3 and a 4th as a booster.
Yeah, and so that's the information we've been given from the kind of chief medical officers, etc. Is that, yeah, it's those on immunosuppression, age, underlying other conditions that might, you might have an immunodeficiency that drives your ITP and a few other bits and bobs, but for the vast majority, not on immunosuppression and otherwise absolutely fine. It's the standard vaccine course.
Yes, and I think it's important for patients with ITP to realise that the ITP itself doesn't necessarily make them at any more risk from COVID. And I think that, because people do worry about that, obviously.
Thank you very much. Now, one here about children and the vaccine. It's a question from Karen James. It's considered that her son or their son developed ITP following the preschool booster vaccination, and after 3 successful flu vaccines, the 4th flu vaccination apparently knocked their son out of remission. Would it be sensible for their son to receive the COVID vaccination? He's currently 11. Well, they've now changed it. The 11-year-olds can now have it now, I believe, can't they? His consultant has said it would be a judgment call. So any views on this, considering his history? Anyone?
So, yeah, this is tricky. So I don't manage children.
Yeah.
I'm not a paediatric haematologist. I'm an adult haematologist, and I think so. I'm coming at this, I suppose, as someone who's got children of an equivalent age, just thinking about the school exposure and minimizing long COVID and keeping them well and at school and all the other things. I mean, my feeling is I think it is a judgment call, but I'm not. Having said that, I'm not. I just would like to declare I'm not necessarily a pediatric hematology expert. Generally, you don't want to get ill with these things, but yeah, I'm probably not the best person to answer that question. I'm sorry.
That's probably a question I can actually put to John Gregory and I can get his answer. and get back to the person. Yeah.
Yeah, I think the paediatric group will have a position
will,
on this actually, because I haven't, I think, I'm not sure, Sue, either, or Adrian, there will be the yellow cards for the children and a few other bits and bobs, and I'm not privy to any of that additional information that would give me any more than is available.
But you're right, it is a judgment thing, and there's no doubt that COVID in children of that age is actually a pretty trivial infection for the majority of them. Looking at the data, I was looking at the data earlier this week on that. I mean, there was the comment that 1 in 100 children with COVID are admitted to hospital, but actually 50% of the children in hospital with COVID have been picked up because they've gone in with something else. And in fact, the 100 is probably much higher. It's probably 1 in 500, 1 in 1,000 children with COVID, because the majority don't get tested, or if they are tested and positive, it's not reported. So actually the incidence of COVID, severe COVID, is very, very small. And the majority of children who have problems with COVID are those with immune deficiencies or other conditions that makes them very vulnerable. So for someone who's otherwise fit, the risks from COVID are actually extremely small. So it is a call, but I think it's something I wouldn't want to make any definitive statement on, because like Vicky, I'm not a pediatric doc, but that's those are just my thoughts on that.
Okay, Mel, you got your hand up, dear?
Hi, yeah. I was diagnosed with ITP in June last year after my second AstraZeneca vaccine, within 2 weeks of the second vaccine. I didn't know what was happening. I was just bruising. I was very tired, falling to sleep at 5:30 in the evening. And I don't know whether to have a booster. So I'm on Revelade, 50 mils of Revelade every day. The steroids didn't work. The platelet count just dropped again. And I just want to have the booster, but I'm unsure whether it's the right thing to do.
Mel, we do know from some of the data in the MHRA cases that there is a higher risk of developing relapsed ITP after your next vaccine, but we still do recommend it because it is the minority of cases. The majority will not relapse. But it's a significant minority, and we do advise now that people have their platelet count checked at 2 to 7 days after the vaccine, so that there can be early intervention. And so just make sure that your doctor is aware when you're getting your booster, and that a plan for repeat platelet count is checked. Hopefully you won't relapse again, but it would still be our recommendation to protect yourself against COVID-19 infection.
Okay, thank you.
Has your platelet count responded to the Revelade?
Oh, huge, yeah. But to be fair, we're a bit unsure because I was very ill over Christmas with that crazy sinus thing that was going around. It wasn't COVID, it was a very bad cold. And luckily for me, I'll say it was lucky, my platelet count shot through the roof because I think my body was too busy fighting the infection. But since then, unfortunately for me, I tend to bruise as soon as my platelet count drops below 60. I'm bruising quite bad as well. So I kind of know. But the Revelade seems to be working. It's keeping it in the 400s.
And I think it can be, you can often feel a pressure when you're trying to make the decision, can't you? And you think, oh gosh, and if it's the wrong one or something happens, I'll be kicking myself. And I think it's really hard. I think it's hard for everybody. And I think it's even harder when you've got something like ITP in the mix. If you have responded to Revelade, I know you didn't respond to steroids. If you have responded to Revelade, then you have a fallback, as it were. So and as Sue said, keeping yourself well, because COVID itself can cause problems. We have had our ITP patient relapse with COVID infection. Generally keeping yourself well and protected, particularly if you've responded to other therapies, on balance, gives you some reassurance, I think. down the line if you do have it. But as Sue said, it is important to get that platelet count checked so you can intervene early. It sounds like your symptoms come fairly early and the platelet count dropping, but it is worth checking. And you know, the guidance is a bit more certain now that we should be checking rather than just, you know, see how you feel.
Are you still taking the Revelade, Mel?
Yeah, I've been on the Revelade for about since Christmas. Yeah, a couple of months. So they just dropped me down to 250 ml every other day, but it's not enough. It's I can tell that I'm starting to bruise again, so I know it's on the way down. So I just
the likelihood is if you responded to Revelade and you're on Revelade, you will have the booster without much problem.
Brilliant. Yeah, that makes me feel so much better.
And the booster is going to be Pfizer or Moderna. And actually, coming back to the previous question from Karen about her son, children of that age would get the Pfizer vaccine. They wouldn't get the AstraZeneca. And obviously the risks of thrombocytopenia with that are much less, as we've said.
Thank you. It's made me feel so much better.
Thanks, Mel. Thank you. Okay, I've got a question here from Andy Bacon. So let's read it out. It's quite lengthy. In April 2021, I was hospitalised for a few days with a count of 5, just a few days after my first and only vaccine, and have since been on treatments to promote platelet production. In the past 2 to 3 months, they have been stable and at a safe level. From that date, and perhaps understandably, I was advised not to take any further vaccines, but perhaps medical understanding has widened since then. My issue is to receive advice as to whether further vaccinations are safe and to have, and given the possible risk, what support network can be mobilised to manage my health during the period after further vaccinations, should that recommendation be the course of action. My GP has devolved responsibility to my haematology consultant, who is managing my return to safe platelet levels. My consultant has said that on this matter, he has no expertise or data to call upon. He has also said that at Warwick Hospital, even the person leading the COVID response is unable to provide the advice he seeks. So should he have further vaccines or not? That is the question.
We can, well, there's quite a few things, I think, and you know, I think understandably, Andy, obviously it's been a tough time for you since April. So firstly, to support your consultant, and feel free to feed this back, as Sue mentioned, there is a kind of national meeting panel with experts on, or at least people who've got a reasonable amount of experience in this area, and we're trying to pull it all together, who sit and talk through cases and offer advice perhaps to consultants that don't see so much ITP on a regular basis. So first of all, if your consultant doesn't feel able to support you through the next vaccine dose, or at least feels that he or she would like somebody to lean on and discuss through the options, etc., and comes and presents your case and what treatment you've had, what you have and haven't responded to, etc., then I think that would be a really good forum to provide some support to them, to then provide support to you. Secondly, if you have responded to ITP treatment and platelets as a safe level, certainly our practice would be to proceed with the next vaccine. If your platelets are stable, you've got some treatments you know you've responded to, we would be talking through our patients and saying, you know, we would generally want to keep you well, protect you from COVID, for all the reasons as discussed, but that once you've had the vaccine, which would be a Pfizer or a Moderna now and not an AstraZeneca, you need to have a platelet count done, ring it through to us, we'll see how you're getting on. If it's dropped, we'll talk about our rescue options, whether that's something like immunoglobulin or whatever at the beginning, and upping the other therapy that you're on that's stabilised your platelet count. So I think it isn't, I don't think it's a reason not to have another dose, providing you've had some response to some therapy and you're not running into problems. And even some of our patients with platelets of less than 10, as discussed earlier, have very successfully had the vaccine with absolutely no problems and no bleeding. Doesn't help you if you're the one person that is struggling a bit, but I think if you have that infrastructure network for you, but also for your consultant via that panel, and you know, I'm sure Sue wouldn't mind being emailed, I don't mind being emailed by your consultant if they want to just chat it through to help support you, then that's fine too. Sue, I don't know if you want to add anything to that.
No, I think that's summed up beautifully, Vicky. Absolutely, we are always here to help consultants and support consultants and just give the best of our knowledge. That's all we can do at the moment. On balance, we do advise further COVID-19 vaccines, and it wouldn't be the AstraZeneca this time.
Okay, thank you for that, guys. There's another message in the chat from Beverly Barr. I was also told not to have my second vaccine originally. With the rise of Omicron, the risk analysis has altered. So I had my second on the 21st of December. Platelets did not move before or after, remained at 7. I'm currently due to have my third primary. My question is that I'm due to have it subcutaneously, which is causing a problem getting it booked. Would you think an IM injection would be okay? Now, we've had this similar question about subcutaneous from another patient as well, when it's, having trouble getting them booked.
So it's interesting, the subcutaneous versus IM, and actually the mass vaccine program for COVID again has changed. So I have two hats. I have an ITP hat and I also have an inherited bleeding disorders hat, and Sue has likewise a lot of experience with inherited bleeding disorders. And historically, if the platelet count is low or you have an inherited bleeding disorder, we've always said you must have a subcutaneous vaccine. Now, with the COVID vaccine, there was no licensing for the subcutaneous, and so people have had intramuscular. And to date, we've not seen huge problems with patients bleeding into the muscles as a result of an intramuscular vaccine versus subcutaneous. So generally, again, we are saying proceed. Now, what I might do if somebody's platelets are less than 10 is give them a medicine called Tranexamic Acid. So Beverly, I don't know if you've heard of that. It's something that just reduces bleeding a little bit and is a clot stabilizing medicine. So I would be inclined, if your platelets are less than 10, my practice would just be give 48 hours of Tranexamic Acid just to reduce any risk. But actually, we have seen not a single intramuscular hematoma with any of our inherited bleeding disorder patients or our ITP patients with platelets of less than 20 having an intramuscular vaccine. Sue, I don't know whether you've had any.
No, absolutely. And we have been recommending that people receive the COVID-19 vaccine intramuscularly. And of course, ITP patients on the whole have less bleeding complications than those with inherited bleeding disorders that Vicky's just talked about. So unless you are very hemorrhagic when your platelet count is less than 10, with sort of a lot of bruises, a lot of nosebleeds, buccal, blood blisters in the mouth, then our recommendation would be to have it intramuscularly. And yes, I agree with the tranexamic acid as well.
And also press on the injection site for slightly longer, 5 minutes at least.
Okay. Right, I will I'll feed that through. I might get, because I've sort of walked around with my letter and I've been in 3 times on 3 bookings and they keep going, oh, we said we could, but we can't. So I've sort of had to come away. But when the GP was there for my second, he did do it that way. So I have had one done that way because the GP was there and was able to sort of override. But that's great because the appointments are getting fewer and fewer between because obviously the bulk wave has gone through. And I just now getting a bit sort of like, now I've got my head in this mindset of having the injection. It's like it keeps on being taken away from me. Okay, fine. I will talk to his lordship and tell him what you've said, and his lordship being my honoured leader and consultant.
Good luck. I'm sure
he'll be in touch.
Thank you very much, Beverly.
Know him.
Okay, I've now got a question from Dina. She was diagnosed with ITP at the start of the pandemic, nearly 2 years ago, and has been taking MMF, mycophenolate, initially 1,000 milligrams daily, reduced now to 500 milligrams. I'd like to know what, if any, are the implications of longer-term immune suppressant treatments on vaccine and booster efficacy for ITP patients, and whether immune suppressants such as MMF for ITP patients at higher risk of falling ill with more severe symptoms if they do catch COVID. I have had, she's just reiterate, she's had 3 doses So she's had 3 vaccines.
Okay,
Right.
I think the first thing to say is well done for having the 3 vaccines, because that's really important. We know that the immunosuppressants such as MMF, rituximab, reduce the immunity that is achieved by the vaccine against COVID-19. But that substantially increases after the 2nd dose and again after the 3rd dose. So that was really important that you've had that done. So we're pleased about that. In terms of if COVID infection does take hold, there is a slightly higher chance of being admitted to hospital with it, and it's always a balance between managing your ITP, which is very important, and not giving you too much immunosuppression during this time of the pandemic. And these are carefully balanced, and it can only be individualized, that kind of management.
Great stuff. Thank you, Sue. So just on that, so that's exactly the same for rituximab as well, because we've had another question on the same theme. Yeah, great stuff.
Yeah.
Thank you.
Yeah.
Thank you. Right, Moira has got a question. Platelets were good for her in December at 119, but last week they had plummeted to 32. She had been averaging around 60 over the last year. She had had her 4th vaccine just a few days before this latest platelet reading. Could there be a connection? From what we've heard, it's possible there could be.
Yes, I mean, you know, it's on the shorter end of what we would be thinking about, but I think yes, and this is why generally we just ask patients, particularly the platelets aren't normal or you know, on the lower side going into vaccine, just to keep an eye on it. I think the key is, for me anyway, is whether it pushes you into a bracket that needs treatment. And I think at 32, generally speaking, for most patients, it doesn't. You might have a higher threshold if you've had a couple of other things happen to you in the past, and your haematologist will discuss that with you, I'm sure. But generally speaking, it's just about whether you head into that territory of just needing something to bring that platelet count up. I would probably get another one done a week or so later and just see what it really bottoms out at, or sooner if you get bleeding symptoms, a lot more bruising, you know, nosebleeds or blisters in your mouth. But yeah, I think it is on the short end of association, but it potentially could be. Yeah, I would think.
Okay, Maura, did that answer your question? I know you're on the call. Is she still muted? No. Okay. Got another question, both on the same theme. Well, 2 questions, but both on the same theme. Do you think that with all the developments that are going on with the vaccines during the COVID pandemic, and the direction or the focus is actually put on ITP, do you think there's a possibility that this could speed up developments of treatments for ITP? About 3 or 4 people have asked that question. So I think the short answer is yes, actually, and I suppose alluded to it slightly earlier, in that if possibly some of the novel approaches to ITP, but actually more about how we use existing treatments and in what time frame and in what sequence. And I think that's COVID has given us an opportunity to really understand that in more detail. So, for example, through the ITP registry, we've been looking at the changes in treatment patterns for ITP pre-pandemic, and then over the kind of 2 to 3 years that we've had run up to pandemic, and then the 2 main years in the pandemic. And we've certainly seen a shift in the types of treatments used. So a move away from immunosuppression. And that's not to say that immunosuppression is the wrong thing, because for a group of patients, it's absolutely the right thing.
but definitely moving away from immunosuppression to try and avoid that more severe COVID in that small group of patients that might be susceptible to it, and also allow best vaccine response. So moving into this kind of romiplostim, eltrombopag, but also much earlier, and then understanding what the implications of using those medicines a little bit earlier as far as response rates, outcomes, how patients feel. Now, we haven't got all the complete data yet, so I haven't got anything to formally share, but hopefully at the support convention and kind of later on in the year we will have. So I think it has given us an opportunity to very much understand and allowed us, or brought more people together at a research level very quickly to try and get on top of this and answer these questions for patients, which has kind of nudged things forward 2 or 3 steps, which I think is fantastic. The other great piece of work, which I'm going to put Sue on the spot now, is Sue did an audit of the management of ITP in the pandemic, which I thought was just brilliant. She got everybody going, loads of responses, got the registrars and the consultants on the ground. So I shall hand over to Sue to talk about that bit, because I think that's led on, you know, that's fed a lot of questions for the rest of us to start to answer with the bigger repositories as well.
Yes, thanks very much, Vicky. It was really eye-opening, actually, this real-world study that we did, and there were 343 patients' data entered, and so we were able to see some ITP that was secondary to COVID infection and how that behaved. There were 23 cases, of which half were admitted to hospital. And those on MMF needed more hospital admission than the others. We were able to see the vaccine-induced ITPs as well, and when they particularly happened after the vaccine. So it was around 12 days where most people presented after vaccine, and again more so with AstraZeneca. And we were able to see the effects of using romiplostim and eltrombopag as first-line agents, which we were allowed to do by NHS England just during this pandemic to try and avoid too much use of immunosuppressants during the pandemic. And as Vicky said, for some people, immunosuppressant is the best treatment for their ITP. But where we can avoid it, we were able to by using romiplostim or eltrombopag. And we found that they were really successful as upfront treatment. So the response rate was 82% with these drugs. So that was new information for us, because prior to the pandemic, we'd not been able to use them as upfront treatment. We always had to have steroids and intravenous immunoglobulin or rituximab or even splenectomy before the use of these romiplostim and eltrombopag, and soon to be avatrombopag as well. Then we were lucky enough that the splenectomy bit got dropped, thankfully, probably 4 or 5 years ago. But we still needed first-line standard agents with steroids and IVIG first. So this has been a great opportunity for us to assess how well these drugs, which is stimulating platelet production, how well patients do on those as upfront therapy. And we were pleased to see that they are very successful. At the end of the day, a license is a license, and the drug companies have to go through a lot of steps to achieve their license for particular indications. And so that will still have to happen. But while we've got the pandemic, we've been able to seize this moment.
Thanks. It's worth just using this opportunity to reiterate a point that Vicky mentioned, which is to advertise the ITP Patients Convention on the weekend of May 14th, 15th, because we're going to be exploring some of these issues in much more detail, particularly newer treatments and the possibility of cure. David Cooter's presenting that. He's a very eminent ITP physician from the States. We'll also be looking at the ITP post-vaccine audit data that Sue has been talking about here. So there are going to be lots of good talks during that session. So just to encourage people to register for that and come and support us.
Thank you, Adrian. You just pinched like a part of my closing speech then, never mind. No problem.
Before
Rhonda.
you close, there are a couple of questions which I think Vicky and Sue ought to just mention. which is the issue of antiviral treatment. What they consider about that for patients with ITP, because if they're on rituximab, or if they've had rituximab, they probably fall into the recommended category. But what about patients, say, with a platelet count of 70 on no treatment? If they get COVID, their counts may fall. Should they be someone you'd consider for a supply of antiviral treatment?
So they are not, so you're right in that potentially the platelet count may drop, as we've discussed. But the current criteria for accessing those medicines doesn't include patients. It includes patients with autoimmune diseases on immunosuppression. It doesn't. That's my understanding. That was our info that we got from the.
Yeah, that's the data. That's the data they've put out. But yeah. I wondered if you can stretch that.
So we have not been able to stretch that. Whether that is region specific, I don't know. But in our region, it's been what's been put out as this is what can be accessed. You're quite right in that, you know, potentially if there's a consequence for somebody whose you know, platelet count, like you say, is 10 or, you know, 20 or something, and if it drops further, the consequences of that are great. But as yet, through our COVID delivery medicines unit, the criteria has been quite fixed. I don't know whether it's any different in Oxford.
No different. I haven't actually had the need to try and stretch that definition. But again, if there was COVID infection, it would still be the minority who get relapse of their ITP, and there are treatments to deal with it. So it might be difficult for us to push that criteria for being allowed those antiviral medications. Certainly if they're on immunosuppressants, yeah, but I'm not sure if they're not on immunosuppressants that we'd get that.
Okay, and I think that answers some of the questions that were put in the questions as well.
Thank you very much, Adrian. Thanks, Sue and Vicky. Rhonda, you got your hand up.
Yes, well, that was something I wanted to know as well. And if you have, if you've had a splenectomy, are you in that area where you could ask your doctor for the antivirals if you get COVID? No.
So I think that's more on the cusp than Adrian's one. I don't think we haven't been asked specifically. But I think potentially splenectomy does increase your risk. Generally, the feeling is it increases your risk more of bacterial infection. But I think generally, you could I would try for somebody who's had a splenectomy. I think I would give it a go, even though it's not technically an immunosuppression.
Thank you. And the other thing that I was interested to hear throughout this evening is that it seems that people who've had a drop in their platelet count have been treated very quickly. And in the past, we've often heard the doctors say, well, wait and see for a bit before you jump into giving treatment. And I just wondered if you'd like to comment on that.
Rhonda, I don't think it would be any quicker than our normal management of ITP. So if the platelet count was comfortably staying at more than 30, that we wouldn't just treat because it was vaccine induced or potentially vaccine induced. So our management of ITP would be exactly the same as for any patient with primary or secondary ITP.
It seemed that some people had a lot of different treatments sort of in a fairly short time, and I just wondered if that would have been a normal course.
It might be if you present with a platelet count of in single figures and that doesn't respond to different lines of treatment, then I think it's probably I think we would have patients like that even pre-vaccine who would have been through several lines of therapy over 6 to 12 months if their platelet count wasn't coming up with each of those individually.
Thank you.
Okay, thank you, Rhonda. KW, you've got your hand up and we're coming to the end now. You got a question?
Yes. Hello, I am here from Germany. My English is not so good, but I think it's okay. I had another presentation just some minutes ago, and I'm here for the last 10 minutes, and I would like to know if it's possible to see the presentation once more. Is it recorded?
Yes, this will be available on our YouTube channel by the weekend.
Okay.
On our website, yeah.
Okay, then it's okay. Thank you very much.
No problem. Thank you. Thank you. Okay. Just one quick question. On here, where's it gone? Someone, a lady was saying, Anita, she's saying, since the start of the pandemic, you know, we was always told that COVID could be spread on surfaces and mail packages, letters, etc., and all that. And she's been religiously, you know, spraying antibacterial stuff, you know, wiping everything over. Should we still be doing that?
Yeah, I think with the full vaccination program, you're very protected from being admitted to hospital with COVID and getting severe COVID. But nevertheless, the rules still apply about being careful, washing hands, wearing masks, try and keep social distancing. And it's just sensible and prudent to do so. So I would advise, yes, to continue with that.
Can I just add to that? So that was my question. Thank
Yeah,
you. So is it too much? Is it OTT to be wiping literally the food shop? So I'm currently just wiping everything. Is that, like, how far do you go? Because a lot of my friends, like if I go to my friend's house and they'll test before, I can't guarantee that they've wiped everything, and I don't think that they will. So how do you,
Anita, you look very young, which is in your favour when it comes to COVID-19 infection. Are you on immunosuppressants?
No.
No. I think you don't need to be quite as religiously involved in that. And I notice on the chat, actually, there's a very important question from Curtis to everyone. And I think we need to reiterate this because it's perhaps repeating what Adrian said earlier, but it is important. ITP is not considered an immunocompromised condition. So with ITP, you are no more risk at COVID-19 unless you are on immunosuppressants.
So it's okay to not wipe everything?
The amount of virus, potential virus on external objects is extremely small. If someone with COVID sneezed onto something that you then touched, you may pick up a significant load. But on something that's around people who, if they were asymptomatic with COVID, the amount of COVID on anything that they've touched would be absolutely minute. And the risks of it causing any significant infection to you are also very, very, very low.
Thank you.
Okay, right. I think to close the meeting, I'm going to ask my colleague Danielle from Australia. She's got a question. All the way from Brisbane. Go ahead, Danielle.
Hey guys, hey everybody. With regards to the COVID-19 data that's been collected, is that going to be incorporated into the ITP register that you guys have in the UK as well, or will it remain separate, I suppose?
So if it's the Support Association survey, that won't come into the registry. The registry is recruiting well, actually, even despite the pandemic. I mean, many trials that weren't specifically COVID had to stop. We're very lucky that many sites have continued to recruit in. So we will have the registry data set that is where information is added by clinicians or their data managers and their trials team. The patient support survey data won't feed into that, but is likely to be in parallel. Sue and I have talked about the two separate surveys about management of COVID in the era and the registry, and how we work together to kind of capture as many cases in that setting so that we can move forward. But the patient support one is separate.
So answer your question, Danielle? Yeah.
Thank you. Yes, thank you. That's great.
No problem.
Because obviously data is key, and what happens today may be very different, or may be really helpful in, say, 5 or 10 years' time.
Yeah,
So,
absolutely.
yeah.
Absolutely. Okay, thank you very much. Just got one last question here. This is from Gianluca. I've been shielding since the start of the pandemic because I had a splenectomy a few years back, and I've had all my vaccines. Is there any advice on how I can get back out and about with confidence? I'm on lifelong antibiotics, 29 years old. That'll be the last question. So anyone want to jump in there?
Well, I think, Gianluca, you've done everything you can to protect yourself. You know, you've kind of done the stepping back and the shielding bit at the beginning, and then had your vaccines. I think, you know, you've protected yourself as best you can. Whilst we are aware splenectomy does affect immune response, it's not heavy immunosuppression, as it were. But I do think, and I think this raises a question for all of us, not just ITP, around the psychological impact of the pandemic and how to get back to normal, how to manage the anxiety around it, and how to do it in a kind of stepwise process. I think on a practical level, I would bit by bit get yourself out and about. You know, introduce kind of getting back out from shielding slowly, mainly for your psychology rather than a COVID risk. But you've done all you can to protect yourself, and you know, you can't protect yourself any more than you have. And I think once you're fully vaccinated, then hopefully you can safely get back out without too many issues. And as we discussed before, if you got COVID, to speak to your haematologist about accessing the antivirals potentially, or at least having that discussion. But I think you've done everything you can. I would, if you were my patient, I'd be trying to work out how we can support you getting back out and doing more.
Thank you, Vicky. Rhonda, you got your hand up, just last one.
Yes, I absolutely agree with Vicky. I think I've seen friends who are finding it very difficult to get out, even if they don't have any health issues. I've decided this week to go up to town in the tube, fear and trepidation, but I went with my daughter on last Saturday and did a walk in the park, you know, one of those 5K things. I came first in my age group, I must tell you. I don't think there was anybody else in my age group who was mad enough to go. I walked it. Anyway, I walked it. I came in nearly last in the 300 people who were there. But anyway, going with somebody else, with my daughter, gave me the confidence. I mean, I'm a pretty confident person anyway, but going with somebody else. And then you have to balance the risk. And so I have been up to town a couple of times, and I've gone and seen a few exhibitions that I like, and it's actually made me feel really good. And I keep in the back of my mind that I still have to be vigilant, I still have to be careful, and it is crowded. That is a problem. But, you know.
I think that's the important thing. I think if you feel you're at risk or you are at risk, it's still continuing taking some of the precautions that we've all taken rather than going completely back to normal. I would say the tube itself has been a lot busier in the last week than it has been, and an increasing number aren't wearing masks anymore. So I have
half term as well, Adrian. It's half term, lots of children around.
Hasn't helped. So I think continuing to wear a mask in those sort of situations is important, and just being, as you said, just being careful and cautious, but not wiping everything that you touch.
Yeah, okay. I never did that anyway, but you know, I think there's quite a lot of evidence to say that the surfaces aren't too much of a problem as long as you're washing your hands frequently and being careful generally.
Absolutely, absolutely. Well, I'd just like to thank everyone for taking part. Also, a big thank you to Adrian, Sue, Vicky, Derek and Rhonda, and all of the patients who are here, especially Danielle, who's up very, very early in Brisbane. Thank you for coming on, darling. Adrian mentioned our convention. We've taken the decision, Adrian, myself and Derek had a meeting earlier in the week. We've taken the decision, the very hard decision, that this year's event will be virtual again, because we feel it's a bit too early to actually go to in person yet. And it turns out, speaking to a colleague who was going to help us with the convention, who's in America, other people are doing exactly the same, changing over to virtual. Although the PDSA event, which is scheduled for the end of July, Jeff Cooper says he believes there are discussions going on all the time about what to do, whether they have their event as in person. So we're not the only ones to switch to virtual this year. There will be others, but I'm sure over 2 days it will be an excellent event, as it is always. I'd just like to say thank you, everyone. The recording for this meeting will be up within the next day or so on our YouTube channel, which is accessed through the website. So thank you and good night.
Thank you, Mervyn. Well
Good
done.
night, everybody.
Thanks.
Good night.
Nice
Thank you,
to see
Mervyn.
everyone.